Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dania Reynolds. Today's episode is on the treatment of skin and soft tissue infections, featuring Dr. Kyle Molina, who is an infectious diseases and antimicrobial stewardship pharmacist at Scripps Green Hospital in La Jolla, California. Listen as he discusses guideline recommendations for treatment of both purulent and non-purulent skin and soft tissue infections, challenges with IV and oral antibiotics, and the role of long-acting lipoglycopeptides in the treatment landscape. This episode is taken from our series, Lose the Line, the role of long-acting lipoglycopeptides in treating acute bacterial skin and skin structure infections. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Molina.
Hi, this is Kyle Molina. I'm an infectious diseases clinical pharmacist at Scripps Green Hospital in La Jolla, California. Welcome to this Medical Minute. We'll be talking about the treatment of skin and soft tissue infections and the role of long-acting lipoglycopeptides. Let's talk a little bit about the definitions of skin and soft tissue infection. Skin and soft tissue infection is defined by the FDA as acute bacterial skin and skin structure infections. Now, this definition encompasses a whole host of different diseases. So it's made up of first cellulitis or erysipelas, and this is a diffuse skin infection characterized by spreading areas of redness, edema, and/or induration. And this is generally a non-purulent infection. In contrast, wound infections, which are defined as purulent drainage from a wound with surrounding redness, edema, and/or induration, and major cutaneous abscess, which are a collection of pus within the dermis or deeper that is accompanied by redness, edema, and/or induration. And these are typically at least 75 centimeters squared of surface area. These are purulent skin infections. In terms of treatment, our 2014 IDSA guidelines regarding the treatment of skin and soft tissue infections really divide up treatment into the treatment for non-purulent skin and soft tissue infections and purulent skin and soft tissue infections. And this is really based on the underlying microbiology, which is likely to cause each entity. So for non-purulent skin and soft tissue infections, these are generally necrotizing infections, cellulitis, or erysipelas. And these are more associated with streptococci, and specifically group A streptococci. And therefore, our antimicrobials for treatment will really target that organism. And once we've determined that a patient has a non-purulent skin and soft tissue infection, we then try to classify this in terms of severity into mild, moderate, or severe infection. And that will determine the route of administration and the clinical path for that patient. So for mild infection, patients will generally receive oral antibiotics. For moderate and severe infections, patients will generally receive IV antibiotics that are either fairly targeted or more broad spectrum. And then for severe infections, these patients will also be evaluated for surgery in case debridement is needed. And eventually, once we see response to our initial IV antibiotics, patients are transitioned and de-escalated to a more targeted therapy that's often based upon culture results that are obtained earlier. In terms of the treatment of purulent skin and soft tissue infection, purulent SSTIs are generally furuncles, carbuncles, and abscesses. And in this case, we're trying to target Staph aureus in addition to our streptococci. Now, again, we stratify this into mild, moderate, or severe infection. For mild infections, generally incision and debridement is sufficient without antimicrobial therapy. And in cases of moderate infection, incision and debridement, in addition to oral antibiotics, are the treatment of choice. With severe infections, we often need incision and debridement and IV antimicrobials, which are again de-escalated to a defined therapy based on our culture results. Let's take a look at our empiric treatment options for non-purulent SSTI. So we have oral treatment options like cephalexin and penicillin, which are dosed every 6 hours. These are generally well tolerated, but associated with some GI adverse events. And as we know, penicillin is associated with hypersensitivities and allergies. We also have clindamycin, which is an oral and IV treatment option. This is dosed either every 6 hours or every 8 hours, depending on the route of administration. And clindamycin is associated with GI adverse events, including being one of our highest risk antimicrobials for Clostridioides difficile infection. We also have IV options such as cefazolin and penicillin, and these are dosed between every 4 hours to every 8 hours. These are also well tolerated but associated with GI adverse events. Let's take a look at our options for purulent SSTI. For oral options, we have a few options, such as trimethoprim sulfamethoxazole, doxycycline and minocycline, and linezolid. Trimethoprim sulfamethoxazole is generally dosed twice a day, but it is associated with hyperkalemia and acute kidney injury. Doxycycline and minocycline, they're conveniently dosed twice a day and associated with photosensitivity, esophageal ulceration. Linezolid is also twice a day, but is associated with myelosuppression, particularly with longer courses of treatment, as well as peripheral neuropathies and rarely lactic acidosis. Clindamycin can also be used for purulent SSTI. And in terms of our IV options, the gold standard has historically been vancomycin, dosed every 12 hours or based on therapeutic drug monitoring. Vancomycin is classically associated with acute kidney injury. Daptomycin is another IV antimicrobial, which is dosed daily. It's associated with muscle pain, rhabdomyolysis, eosinophilic pneumonitis. Ceftaroline is another IV antimicrobial, which is dosed every 12 hours, but is associated with rash and myelosuppression, particularly with the higher doses and longer durations of therapy that some patients may require. Due to the high rates of community-acquired MRSA, empiric coverage for MRSA in patients with purulent skin and soft tissue infections are recommended per the guidelines. Once we've defined our organism in purulent SSTI, we do have some options, particularly if MSSA is identified, where we can de-escalate from antimicrobials covering MRSA to antimicrobials covering methicillin-sensitive Staph aureus. Our oral options are cephalexin or dicloxacillin, which are both dosed every 6 hours. And our IV options are cefazolin or nafcillin oxacillin, which are dosed between every 4 and every 8 hours. Nafcillin and oxacillin are notably linked to hepatotoxicity and nephrotoxicity. There are some logistical challenges with IV and oral antibiotics. Patients may be unable to tolerate antimicrobials due to their adverse effect profile, or these potential adverse events can interact with selected comorbidities that the patient may have. Oftentimes, outpatient prescriptions can be cost prohibitive for patients, particularly if they're uninsured or underinsured. And then there are issues with dosing frequency, especially those every 6-hour antimicrobials that we discussed. This may decrease adherence and therefore ultimately result in a worse outcome for your patient. Further, if a patient does need IV therapy, usually it requires that they're hospitalized and or they need outpatient antimicrobial therapy, which comes with other risks. The average length of stay for a patient admitted for a skin and soft tissue infection is about 5 days. It's even longer if a patient has an infection due to MRSA. This results in a cost of approximately $8,000 per patient, and so hospitalization can be very costly for your patients. In terms of the location of care for SSTI, we have a few options. You can discharge a patient home with oral antimicrobials, and this is preferred for mild and moderate infections. Oral antibiotics are generally inexpensive and typically well adhered to, but patients can run into adverse events, and with some of our antimicrobials, the frequency can be prohibitive. Oral antimicrobials may also be a challenge in selected patient populations, maybe those with mental health conditions or substance use disorder, where adherence is not as optimal as the provider may like. We can also discharge patients home with OPAT or to an infusion center. This would allow the patient to return home to their activities of daily living, but it also may interfere with their routine day-to-day activities. Going to an infusion center daily may interfere with their work. Infusions also usually require placement of an invasive line, and there are risks of complications like infection or thrombophlebitis from placing that line. In addition, there are logistical challenges with setting up home health and infusion services, and this tends to be more costly than discharging patients home with just oral antimicrobials. And so this is not an option for patients who are underinsured or uninsured. Another option is to put our patient into observation, and we can give doses of IV antimicrobials for a few days and see what the response is before discharging a patient with PO antimicrobials or home with OPAT. The benefit of this approach is increased healthcare provider oversight, where we can see the initial response and ensure that the medications that we're giving to our patients are effective. The downside of this approach is that it increases our healthcare related costs for the patient. This is still less expensive than admitting our patient to the hospital, where costs are even higher. Finally, we can admit our patient to a hospital for IV antimicrobials. Similar benefits as observation. We can see resolution of the infection, and generally we can see resolution over a longer period. The downside of this approach is increased healthcare costs over every other approach. Let's talk about long-acting lipoglycopeptides. Dalbavancin and oritavancin were FDA approved for the treatment of acute bacterial skin and soft tissue infection in 2014. These agents target transglycosylation and blocking of elongation of peptidoglycan chains, and oritavancin additionally inhibits transpeptidation and disrupts membrane integrity. These are highly active against gram-positive organisms. When we look at the PK/PD profile of these agents, the AUC over MIC is the predictor of pharmacodynamic activity. And what this allows for is higher doses of the antimicrobial to be used for less frequent dosing. Let's take a look at the DISCOVER trials for dalbavancin for acute bacterial skin and soft tissue infection. The DISCOVER trials were a double-blind, double-dummy, multi-center randomized controlled trial conducted in 2011 and 2012. This included patients with cellulitis, major abscess wound infection with greater than 75 centimeters of erythema requiring more than 3 days of IV therapy, and they had to have more than one systemic sign of infection. So 25% of these patients had fever, and there was less than 30% who had a major abscess. These patients were randomized to a 2-dose regimen of dalbavancin that was 1,000 milligrams IV on day 1, followed by 500 milligrams IV once on day 8. This was compared to vancomycin, dosed at 1,000 milligrams or 15 milligrams per kilograms every 12 hours for 3 days. And there was an option to switch to oral linezolid to complete a 10 to 14-day course. The primary endpoint was early clinical response at 48 to 72 hours of therapy, which was defined as a cessation of spread of erythema and a temperature of less than 37.6 degrees Celsius. The DISCOVER trial showed that weekly dalbavancin dosing was as effective as daily vancomycin therapy. In the primary endpoint in the microbiological intention to treat population, 79.7% of patients randomized to dalbavancin met the primary endpoint compared to 79.8% in the vancomycin linezolid group. And this corresponded to an absolute difference of 0.1%. When we look at the per protocol secondary analysis, rates of the primary endpoint were consistent across Staph aureus, methicillin-resistant Staph aureus, and Strep pyogenes. Results were also consistent among those with diabetes at baseline and those with SIRS criteria present at baseline. A follow-up trial to the DISCOVER trials further refined the dalbavancin dosing scheme for ABSSSI. This trial was a double-blind randomized trial conducted in 2014 and 2015 at 60 centers in the US, Eastern Europe, Russia, and South Africa. And this trial compared a single dose regimen of dalbavancin at 1,500 milligrams once over 30 minutes to the historical 2-dose regimen of 1,000 milligrams IV on day 1, then 500 milligrams IV on day 8. This trial excluded patients with catheter infection, infected devices, diabetic foot ulceration, perirectal abscess, decubitus ulcer, more than 1 dose of antibiotics in the past 14 days. The primary endpoint was the proportion of patients in the intention to treat population who achieved at least a 20% reduction in size of erythema at 48 to 72 hours after initiation of the study drug and did not require rescue therapy. The results of this study were similar to that observed in the DISCOVER study. In terms of the primary endpoint, clinical response at 48 to 72 hours was similar between the single-dose dalbavancin group and the two-dose dalbavancin group. When we look at the secondary endpoints for clinical response at 28 days in both the intention to treat and clinically evaluable populations, results were also consistent. This study showed that a single dose of dalbavancin was similarly effective as a two-dose series of dalbavancin. With regard to the safety of dalbavancin compared with vancomycin in ABSSSI, we have a nice post-hoc analysis of the aforementioned trials. There were fewer adverse events and nephrotoxicity in the dalbavancin group compared to the vancomycin group. So when we look at patients experiencing any treatment-emergent adverse event, that was 26.2% in the dalbavancin group compared to 37.9% in the vancomycin group. Notably, dalbavancin was associated with less nephrotoxicity on therapy, particularly when you look at patients who received dalbavancin compared to those who received only IV vancomycin therapy. So we can see that the rates of nephrotoxicity with dalbavancin were close to a third of that of those who received vancomycin only. These data are compelling to show that dalbavancin is associated with fewer adverse events than vancomycin. Oritavancin was evaluated in the SOLO-1 and SOLO-2 studies. These studies were randomized international multicenter double-blind controlled trials conducted in 2011 and 2012. This trial enrolled patients with ABSSSI who required more than 7 days of IV therapy and had more than one systemic sign of infection. Patients were randomized to oritavancin at a single dose regimen of 1,200 milligram once over 3 hours and compared to vancomycin dosed at 1,000 milligrams or 15 mg per kg IV Q12 for 7 to 10 days. The primary endpoint was composite of cessation of spreading or reduction in size of baseline lesion, absence of fever, and absence of need for rescue antibiotic. The results of the SOLO trials shows that oritavancin was similarly effective to vancomycin. Again, when we look at the secondary analysis of this trial, these results were consistent across our organism types, MSSA, MRSA, and strep pyogenes. Notably, in this study, 5 patients in the oritavancin group developed osteomyelitis after treatment, and this occurred generally within 1 to 9 days after study drug initiation. It is thought that these cases were likely pre-existing at the time of entry, given the rapid onset of the osteomyelitis. However, this did result in a warning and precaution in the package insert for oritavancin to monitor for signs and symptoms of osteomyelitis while on therapy. The safety of oritavancin was compared to vancomycin in a post-hoc analysis of the SOLO-1 and 2 trials. In this study, oritavancin was shown to have less hypersensitivity and pruritus than vancomycin, and also had fewer subsequent admissions than vancomycin. Notably, there was a longer median duration of ADRs in the oritavancin group. These findings are similar to what was observed with dalbavancin and show a similar safety profile between the two agents. In March of 2022, a new formulation of oritavancin, branded as Chimersa, was approved by the FDA for the treatment of ABSSSI. This formulation is developed with 2-hydroxypropyl beta-cyclodextran, and this enhances the solubility compared to the original formulation. Effectively, what this does is it simplifies the preparation so that it can be diluted with either D5W or NS. It reduces the volume of infusion, and it also shortens the infusion time from 3 hours to 1 hour. The approval of this new formulation is based on pharmacokinetic and safety data showing similarity to the original formulation. The new oritavancin formulation was compared to the original formulation in a pharmacokinetic and safety study and was found to have similar pharmacokinetics, as we can see in this concentration time plot here on the left. Additionally, the original formulation and new formulation have similar safety profiles, with similar rates of treatment adverse events, study drug-related adverse events, and serious treatment-emergent adverse events. Let's compare all of the available long-acting lipoglycopeptide formulations. So dalbavancin can be dosed either 1,500 milligram once or 1,000 milligram once, then 500 milligrams 1 week later. This is typically reconstituted in a dextrose 5% in water to a total volume between 300 and 1,500 milliliters. This is given over 30 minutes. Dalbavancin has a half-life of 346 hours. In terms of renal dose adjustment, dalbavancin should be renally dose adjusted at creatinine clearance of less than 30 mils per minute. Dalbavancin is not known to have any drug-drug or drug-lab interactions and is associated with mild adverse events, largely GI and infusion-related reactions. It has a broad spectrum of activity against gram-positive organisms, including VAN-B VRE. Oritavancin has 2 formulations. The original formulation is branded as Orbactive. This is given as a 1,200 milligram infusion once, reconstituted in dextrose 5% water to a total volume of 1,000 milliliters. This is given over a 3-hour infusion time. The half-life of oritavancin for both formulations is 245 hours. The renal dose adjustments are not required. Oritavancin notably has drug-drug and drug-lab interactions. It is a weak CYP3A4 2D6 inducer, a weak 2C9 and 2C19 inhibitor, and may interfere with coagulation testing. The oritavancin new formulation has the same dosing as the original formulation, but can be reconstituted in either dextrose 5% water or normal saline. This contains the cyclodextrin vehicle. This is reconstituted to a total volume of 250 milliliters and infused over 1 hour. Oritavancin has broad spectrum gram-positive activity, including against VAN-A or VAN-B VRE, and even versa. Let's talk about special situations like obesity, diabetes, injection drug use, or vancomycin allergy. The efficacy of dalbavancin in patients with obesity or diabetes was assessed in a post-hoc analysis of the clinical trials. In this analysis, patients with a healthy weight or BMI of less than 25 had greater odds of reduction in lesion size at 48 to 72 hours. This might be explained by a higher baseline incidence of cellulitis in these populations, which take longer to resolve. At end of treatment, both groups had similar rates in reduction of lesion size. In terms of diabetes, patients with diabetes at 48 to 72 hours were less likely to have a reduction in lesion size, but at end of treatment, rates of lesion reduction were similar. Oritavancin has been used in patients with obesity or diabetes. In SOLO 1 and 2, over a quarter of patients were obese, and success rates in this trial were high. Overall, the long-acting lipoglycopeptides, dalbavancin and oritavancin, appear highly effective in patients with obesity or diabetes, although clinical response may be delayed in some patients. The long-acting lipoglycopeptides have been evaluated in patients with injection drug use, as seen in the phase 3 clinical trials. Nearly a third of patients in both the Discover and SOLO trials were persons who inject drugs. Patients who received long-acting lipoglycopeptides have similar clinical efficacy as non-injection drug users and similar rates of treatment-emergent adverse events. These data are encouraging that we can safely use long-acting lipoglycopeptides in injection drug users. As long-acting lipoglycopeptides are structurally similar to previous generation glycopeptides, a common concern is about the ability to use these agents in patients with documented vancomycin allergy. Antibiotics in the glycopeptide class contain a heptide core, so there is concern for cross-sensitivity, particularly with the long half-life of dalbavancin and oritavancin. In one case series, 10 patients with vancomycin allergy received outpatient infusion of dalbavancin. 4 of these patients had a previous type 1 IgE-mediated reaction, 1 had delayed rash, and 2 had previous vancomycin infusion reaction. All 10 patients in this series tolerated dalbavancin during the 30-minute infusion without pre-medication, and no adverse events were reported. These data indicate that long-acting lipoglycopeptides may be considered in patients with vancomycin allergy with close and extended monitoring. In the SOLO trials, the median onset of hypersensitivity in patients who received oritavancin was 1.2 days, and the median duration of allergy was 2.4 days. Therefore, monitoring should not cease after the initial infusion, and patients should be counseled on the possibility of a delayed reaction. Given our oral and IV options, what is the role of long-acting lipoglycopeptides in therapy? These agents should be considered if the available oral options may cause adverse events or have caused an adverse event, if there are issues with your patient in terms of GI absorption. These agents are also useful in patients in which there are significant doubts about adherence to oral therapies. This includes patients who are experiencing homelessness, incarceration, or who live in a rural location, those with poor mental or physical health who are unable to take oral medications easily, and patients who inject drugs. These agents are also useful in patients with mild to moderate systemic signs of infection, where traditional IV therapies may have been considered, but this would allow you to avoid inpatient admission or line placement. These agents should be avoided in those with hemodynamic instability or severe sepsis shock, those with lipoglycopeptide allergy or allergy to ritonavir and dalbavancin, although those with glycopeptide allergy to vancomycin can safely be given these agents with close monitoring and follow-up. These should also be avoided in those who require emergent surgery or those where there's concern for necrotizing fasciitis or other infections besides skin and soft tissue infection, which may be polymicrobial, in which case the agents would not cover the appropriate spectrum of activity. They should also be avoided for those with suspected orbital cellulitis. So let's review the treatment of acute bacterial skin and soft tissue infections. The choice of antimicrobial agent and route of administration depend on the classification of the infection and the severity. Oral antimicrobials are preferred for definitive therapy in patients with mild and moderate disease, but the safety profile should be assessed and monitored continually. When the use of oral antimicrobials are prohibitive or when severity might otherwise warrant observation, long-acting lipoglycopeptides are a valuable alternative to avert inpatient admission or eliminate adherence concerns. Data in special populations such as obesity, injection drug use, and those with vancomycin allergies are encouraging and suggest that we're able to use these agents in many of our patients.
Thank you to Dr. Molina, and thank you to the listener for joining in. To listen to more episodes in this series and to see slides on treatment of skin and soft tissue infections, see the links in the show notes. Thank you and have a great day.